Oh, yeah.
that it's scheduled, I mean, tentatively from one to two, but it can last as long as you all would like, and throughout the presentation, if you have questions. I don't have a PowerPoint, just simply because I want it to be more of a conversation and a discussion with everyone rather than having it just be a point-by-point piece of it. But I can share my information at the end if you want, just to be able to have that. First, my name is Darian Dawson, and I have been a patient advocate for 8 years. My background is I am not in the clinical.
Hi, how you doing?
So good, how are you?
I'm feisty as ever. Still trucking.
Well, good.
You too, I see.
Yes.
Very nice.
But I've been doing patient advocacy for 8 years, and my background is working with adults who are developmentally disabled in the community. Then I worked in hospice, and for a period of time, I was a hospice director, so did community-based support there, worked in assisted living for just a couple of years, and then have the rest of the time I worked in home care. And so most of my experience has been in community-based supports, so it hasn't been facility-based support. So the difference with that, and the key, is that there are many things that you're able to do out in the community, and people don't necessarily think can happen. But with community-based supports, there's a wide array of services. One of those was patient advocacy, and I started back, the UW-Madison had started a board certification for patient advocacy, and a colleague of mine had taken the test and gone through it. She had worked in hospice, she was a hospice chaplain, decided to start her own business and do patient advocacy. Another colleague of mine who was a nurse, how I started was a colleague of mine had a client who was in all things in alcohol rehabilitation, and said, would you like help? And I go, and she explained the situation, and I said, absolutely. So and that was how I got, so there wasn't a aha moment, it wasn't oh, I want to be able to help people and this is my path. It was really just simply, this was something that I could do. What I can tell you what patient advocacy is that essentially it should be a person-centered approach to care. Just imagine yourself, how I best describe it is, imagine yourself at the doctor's office. Go by yourself. And it is whether it's a routine appointment or it's a specialized appointment, and go in, check in. I'll go through the process. You check in, sit in the waiting area, have the medical assistant come take you, do your weights, and then they bring you back to the exam room. Then they ask you your medication list. They ask you, how you're doing, are you in any pain, and they check your vitals. And then that's when the physician will come in, or a nurse practitioner, or physician assistant will come in at that point in time. And you're there for the topic of that appointment. When you leave that appointment then, so the appointment could be 10, 20 minutes long, you leave that appointment, you walk out and you get the after-visit summary, or you end up and you're scheduling a new appointment, you get out to your car and go, what did I just do? And what am I supposed to do? And as an example, I just myself had about 3 months ago, I was doing a follow-up appointment, and they go through the MA does, the medical assistant starts going through the list of medication that it looks like an Epic that I'm on. And I had been prescribed a steroid because I had an upper respiratory infection many years ago, and they're like, are you still taking that? I'm like, no, I don't take that. And so that the idea that all of the T's are crossed and I's are dotted does not exist. And that's where patient advocacy comes in. A patient advocate because I have been in that situation where I've walked out of the appointment and been like, well, what just happened? What do I need to do? And because even though I'm a patient advocate, I've been doing it for 8 years, if it's myself, I get nervous in appointments, and I start chatting, and I start becoming, I start joking around. because it makes me feel comfortable. And then I forget what then I am like supposed to do. They're like, well, I'm like, what am I supposed to do? They're like, wait, I have this medication? You know, and because I don't really take that many medications at all. And I'm like, I'm supposed to get this and take this. And then I read then the prescription bottle and I go, okay, like, then I look at it and then see like I'm having difficulty figuring out how often I'm supposed to take it. Then I look at my paper copy of my after visit summary, and that really doesn't explain it. So all of this being said is a patient advocate is then a person-centered approach to care. Typically, there are two reasons why people typically hire a patient advocate. Is that it is because you're having or there's three reasons. Chronic illness, that it has been systemic over a long period of time. It is congestive heart failure, it is diabetes. Those are the two most common that people end up having that have some of the most complicated health conditions that end up having then someone's diagnosed with cancer and they don't have somebody that's immediately there to go with you. Or it could be because you live here and daughter who is helping lives in the Twin Cities or lives in Detroit, some other location in the country. So then that's the person who initially calls me and says, Mom lives in Oregon, she's lived here for 52 years, needs help going to the doctor. And I'm like, tell me more. Well, Mom's 85, has been living in this house for 50 plus years and has a lot of medical appointments, and I don't really want Mom driving or trust Mom driving. And then I meet Mom and she goes, I'm fine. And I go, oh, okay, and figuring out a balance of what to be able to do at that point in time. The other factor and the other reason why people typically hire a patient advocate is when they have, when they found out they have diagnosis of Parkinson's or dementia, like early onset mild cognitive impairment. That would be, so a mild cognitive impairment diagnosis isn't necessarily dementia, but it means that you have symptoms that could evolve and could have that you could end up developing dementia. Now, when I say the word dementia is what I call it, and this is a perfect day for it, but it's an umbrella term. So dementia is that there's over 160 various types of dementia. Most people think of Alzheimer's, Lewy body, vascular. Those are common types of dementia. For that reason, I'll give the example of I have a client who lives at Kettle Park in Stoughton, and I have permission to be able to share information. But daughter lives in Madison, on the west side of Madison. Son lives in Seattle, and Mom wants to be independent. But daughter said, Darian, the first time Mom was here and I took her to an appointment, I drove from my house over by Memorial High School to Stoughton to pick her up, then go to Oregon to the UW clinic, do the appointment, and then go back to Stoughton, and then go from Stoughton to my house. She goes, by that time, I've taken a half a day off of work. So it's typically because of time constraints. So that is that classic sandwich generation of, there's small children or middle school or high school kids, and now your parents are trying to be able to take care of as a daughter, and now the mom has said, oh, you're my power of attorney for healthcare, and so I want you to be able to be in charge of everything. And daughter now goes, wow, what do I do? And I don't know what this is. And that really is so we're typically then being person-centered and focus on goals. So if you were to call me and say we're looking for a patient advocate, I'd first sit down, find out information about what you wanted, what was the purpose of the call. Have you had a recent diagnosis of some chronic illness or you've had a chronic illness for a long time and now it's becoming more difficult to manage that. Or it is, it might be an early diagnosis of Parkinson's or dementia, things like that. Or just having difficulty with mobility. That might simply be it. But there's not a right or wrong reason to call. for that. So, and if anybody has questions along the way, please stop me and be able to ask those questions along the way. But what we then do at that point in time, we being the client and family and myself, is then develop goals around that person and what that person wants. And always that is really from the very first day through the years that I'll work with somebody, that is the driving force of what we do on a daily basis, of really working with those goals. The beauty of the goals is that they can change and that they end up, but the comparison that I always make is like a financial advisor. I'm not a financial advisor, but what will happen is that people will end up developing goals and a plan, and then a year into it have a different plan. And I go, okay, well, our original goal, that we developed a year ago was X. Now what you're telling me is Y. Do you want to change your goal, or are you just having, is this just a frustrating day, or a bad day, or you saw a commercial and now you want to see, talk about a new medication, which happens. I have people call me all the time, like, I saw this commercial, I was watching Lifetime, and I saw this commercial, and what about this? And I'm like, hey, first of all, I don't know what that medication is, to be able to do, but people, can pivot, they can change their goals, but all along, a patient advocate's role is to be able to help support that person in their goals. And that really is that piece of it. Now, there are various levels of patient advocates. I have various colleagues I work with. There's a cohort, a group of us that work together. And in that group, I'll explain that there is a former trauma surgeon who is a medical doctor that's a patient advocate. There's a former pharmacist who now is a patient advocate, former nurse practitioner, a pharmacy manager who had managed a pharmacy for 30 years. Another person is a speech therapist and is doing patient advocacy. And then there's me, that I am the only non-licensed clinical person, meaning I'm not a doctor, I'm not a nurse. My background is in social work and in the crisis management of it. Part of really what the catalyst of starting it was that clients that I was seeing, there was a higher need, is that, home health nurses are great, social workers are great, but that what do you do after the hours of 8 a.m. to 4 p.m., Monday through Friday? What happens if someone has a crisis at 8 o'clock on a Tuesday night? What do you do? Daughter lives 300 miles away. Now this person has a crisis. What do you do in those situations? So that's where patient advocacy comes in. So my background has been. How are you, sir?
Don't worry, I'm a little late.
No worries. You're good.
Okay.
How have you found that?
He's getting to the meat of the thing now.
Oh, I see.
How have you found that the medical society as a whole accepts that? If you're taking something like that with, to the appointments and such?
It much better, especially over the last 5 years, there are more people. So when we go in, like I have a client who I just was with at an appointment, and will right away, she'll go, this is Darian, this is my patient advocate. And right away the doctor's like, okay, perfect, thank you. A couple years ago, people were like, what? And then they would learn what we did, and they're like, that's fantastic, because you now have somebody else who can navigate that. So that is, yes, it's people overwhelmingly like that they have a patient advocate, because our role as a patient advocate, we're objective as well. Like we can separate, like that is not my mom, that's not my grandma. If she doesn't want to use her walker, well, there's a risk to that, but that's okay. So I'm not, getting upset because my client doesn't want to use a walker when, it is recommended that she does, but there's a higher risk of potential falling, with that. So, but overwhelmingly positive that the healthcare industry really likes patient advocates. So that has been my experience. It's just been patient advocates have been attending appointments and being able to do proper follow-up, and people are starting to recognize. And I've been working now with physicians for many years with clients. So my longest client I've had is 8 years. One of my second client I ever got, I still have had after 8 years. So but it just varies. I've had some clients for, one visit, and others I've had for multiple years that way. But yeah, overwhelmingly positive. So that's a great question.
Yeah. I'm thinking, do you work mostly with people in their own home, or could you help people in the nursing home? Do some of your advocates consider the nursing home their main avenue of support, or are there other, do you divide yourself between home and nursing home, or do you have other people who do nursing home and other people who do,
Yeah, it doesn't matter where the person lives, so whether they're in a skilled nursing home or assisted living or memory care or home, it really doesn't matter what the setting is, like what a care setting would be. So because the advocacy piece is about meeting their goals, so it's not about, so I'm not the one going in and doing the caregiving and I'm not a home health nurse, I'm not doing those components of it. So it doesn't matter where the person lives.
and you put the resources together for them if they need that. So when somebody goes from home to nursing home, you can follow that person. You
Yes.
don't have to have somebody else pick up at some
Correct.
point.
Yeah, absolutely.
That's
Yeah.
easier for people who have memory issues.
Yeah, I can follow wherever they go, and that's a lot of times too, that people are learning as well that when people start at home, when they move to assisted living, there was this belief that, well, I don't need, a patient advocate after now I move into assisted living. And people found out, and so I would get, a call and say, oh, we're discontinuing your services. And I would just foreshadow and say, that's great. I'm happy that, your mom is doing well and moving in and, she has the support, but if you need me, I'm one phone call away. And typically 2 or 3 months later, I get that phone call and go, this isn't going well, or this has been our second director of nursing we've had since, mom moved in. There's a lapse in communication, what do we do? And so there's nothing wrong with what the facility is doing, it's just that it's just like going again to the clinic. There's a lot of moving parts to it. And, yeah, go ahead.
Oh, yeah, you finish and then go ahead.
The other piece of that too is that it doesn't necessarily mean, as a patient advocate, if there's a group of people here, every single person can have different goals, and what my role is different for each individual person. It would be highly unlikely that if there were 7 people sitting in this room that everybody would want the same thing and have me do the same thing. I've had people where they're like, we want you, like I had a family that said, we want you to coordinate with UW Home Health every day, and which I would do, and can you then call us with the schedule, because they didn't want the calls every day coming in, like saying, oh, hey, I'm John, I'm your PT, I'll be here, between 11 and 1 today. They didn't want those phone calls. So I said, sure, I'll do that, I'll just coordinate with the home health company, and we'll coordinate, and then I'll give you one call, and that's when,
You set up the schedule?
and yeah, and to be able to do that. Other families are like, we got it, don't worry about it. And so every person is different on what I do, and there is when I walk in the door, there's no expectation like, oh, this is what I will do. So any patient advocate you ever work with, that's exactly what they should do. It should really be about what your goals are, what you want to be able to do, so there's not this is a standard every patient advocate will do. The same thing.
So I'm thinking that these could be very busy days. So do you kind of work in tandem with another worker in case you can't pick it up?
I can. I mean, and I've done a couple with that have been more complicated. So I have another patient advocate that I work with, but it doesn't happen that often.
No, yeah.
Typically, I've done it in the past where I've had other people that I worked with, and that works well though if the one person does, like with the doctor and then with the nurse practitioner that I worked with, that they do all the medical appointments and I do all the mental health appointments. So we essentially divide and conquer between those appointments, because usually the nurse and the doctor were like, I just don't want to do that.
Right.
I just don't want it, that's out of my field of expertise. I don't want to do those pieces, so they call me in to do those services for that. So, but typically with most people, they have just one person. You know, there's cases of vacation, you know, where people are away, but it's also creating a system where one person isn't, that client isn't 100% reliant upon that advocate to do everything. The advocate is there to be your voice, not just to be the doer of everything.
Right.
And so that's really the goal of that
Yeah.
person, so, yeah.
Yeah, I just wondered before, the day I go into a nursing home, and I'm still going to see a doctor at doctor's offices and like that. Do you accompany them would you request that from you?
Yes.
Would you be able to go to doctor appointments?
Absolutely.
Or something like that?
Yeah, you
Just
bet.
to keep the doctor, sometimes I think they don't do things that they should be doing. I just don't trust the way I wish I could have, you know. I just don't trust the system as much as I used to. And they put off things. They look over their head at the guy with the three-piece suit, you know. And I'm cautious, you know, and I'm skeptical, and I don't care.
Yeah, absolutely. There is,
Yeah.
it's always up to the individual person. Like, I have some clients who I go with to the appointments, others don't want me to be able to go. Like, I have a client now who, her mental health has improved enough where I was talking to her this week and said, I'm happy to now, like, she had a neurology appointment last week and then a urology appointment this week. And I
Okay.
said, I am happy to, to not go to those appointments with you if you wanted to manage those appointments yourself. And she's like, no, I really feel comfortable having someone else there to be able to help navigate those pieces. So it's always up to the individual person. And, really, when you think about it, a doctor has a snapshot of, 10, 15 minutes to be able to assess and determine what's going on. There really isn't a lot of time to be able to go. What I have found to be the best in those cases is the follow-up in between, is being able to go and following up and giving and so typically when you're gonna call into the clinic,
Yeah.
you're gonna end up talking to the nurse, being able to go, so you wanna relay information to your physician about the information. and things
Yeah,
like
I
that.
call the doctor's office, you always get a response from the nurse that has talked to the doctor pretty much, and then, yeah, you're right about the in-between appointment thing like that, that helps somewhat.
Very much, yeah, to be able for follow-up and to be able to go, because it's not always, they're walking in, and I mean, just imagine doing that 10 to 15 times a day. You're going in and seeing different people on how to manage those things. So it's really the onus is on the person, or then becomes the patient advocate's role to help with that, to be able to help manage those things. Because what I have found too, that because when somebody has a primary physician and then has 3 or 4 different specialties,
Yes.
that I
It's
have
all fractionated, this whole
It-
system is too fractionated.
Yeah, that's-
Nobody really knows what's really going on.
right. I always call it siloing. Is that
Silo,
Silo.
kind of same thing,
Yeah.
silo.
It is,
Yeah.
where somebody has, this is with my client here, she had urology, neurology, and she has psychiatry, then she has a
Oh.
therapist, she has a
Yeah.
primary physician. So right there is just a lot of information, and then to try to disseminate that and try to, communicate between, and then the psychiatrist isn't connected to the healthcare system.
Yeah.
So they can't put a note in Epic to be able to,
That's
which
all.
is the electronic record
Window.
keeping.
Oh.
So the neurologist can't send a note to the psychiatrist because the psychiatrist can't see it. So it has to be then a phone call or a fax.
Yeah.
And you're like, what is this like 1987, a fax machine? I'm like, I didn't know people still had faxes.
That's the facts.
I mean,
Can those services be covered by long-term care?
Yes.
Yeah.
Yeah,
They can?
They
Wow.
can. Yeah,
Great.
the caveat with long-term care insurance is that long-term care insurance will cover it as long as the person is a nurse. If the person's not a nurse, then, I mean, it could be a doctor as well, but the person has to.
Medical.
Yeah, it has to be so it's not necessarily a person, but I've found that, like in the nurses and doctors who do patient advocacy, they're very focused on, the symptom management, making sure symptoms are managed in those pieces.
Yeah.
But yes, 100% could be covered by long-term care insurance.
Well,
Yes.
isn't it important too, and you would be involved in this in some cases, where before you actually go into the office, you've written down, I have these questions.
Yes.
Yeah.
That-
Yes.
have it all ready, so that, because when you get to the office, then you say, oh, I meant to ask him about this or that, no, it's all here.
Right.
You know, that kind of stuff. And
That-
then you're
yeah.
covered, you know, and
That-
you would be kind of talking to people about having that stuff together before you actually see the provider.
Yes, that is, that's a part of the plan, and that is where, so what I will encourage people to do is have an appointment before the appointment. And, you know, what are the goals of this appointment? What do you want to be able to accomplish? When you leave the appointment, what do you want to have done, or what do you want to have seen, you know, completed at that point? So being able to have those goals ahead of time makes the appointments much more efficient than if you just walk in blindly and you're just like, I'm here, you know, that which many people do. I mean, that's normal. And so that when, so getting to your point of how people perceive patient advocates, they love it because then they're like, okay, the patient advocate's organized, they have all this information, you know, and also like we can advocate for people where, how many times if you have, you know, multiple appointments in a week, and like I have clients who, you know, in a 2-week period, they've been to the doctor 3 times potentially. And every time then the MA innocently is asking like, let's go over your medication list.
I know.
Yeah.
And then you sit there and then you ask them and you go, hey, like I just had a client who did that, and I had it on my phone, so I had it ready to go, but I said to the MA, I'm like, oh, person, it was just updated on the 10th of July. And he looks at it and he goes, okay, perfect. No need to do it. No need to go through every single thing, because you're asking a person who lives in memory care, who is now at an appointment, what her medication list is.
Right.
You know, and she's not gonna.
He shouldn't even ask the question.
Yeah,
He should have understood.
And yeah, so for many people, yes, but the ahead of time, being able to make sure what the goal is of that appointment is very important. So yes, that's the, typically patient advocates, in my experience, you should have a patient advocate that bills on an hourly basis. Bills, typically, like I will even bill on a quarterly hour, you know, where because of my background working with adults who are disabled, I learned it's a system of after 8 minutes of working with the client, and then that's when I bill on the 15-minute period. So that is all established at the appointment, at your initial meetings, to talk to people about how you bill and what will be billable versus not billable time, and to make clear expectations, you know, for people, so that you just don't get a random bill and in the mail and you're like, why did they bill me for 3 hours? So like, I'm very clear in mine, and I say that I will bill for in-person appointments, and then if there's tasks that are after the appointment that you want me to be able to do, whether it's following up with the doctor for, you know, getting information or sharing information with them, scheduling additional appointments, sending emails and making sure everything is connected and all the dots are connected, then that is billed at the 15-minute increment at that time.
Are you from an agency, or are you from the sole proprietor, or what are you? It would be considered an independent patient advocate, but then I work for, the company I work for is Comfort Keepers. It's a home care company that, but I'm bonded, I'm insured, and have errors and omissions insurance, so all those pieces. So when you're How do I get a hold of this organization then?
that would be me. I can talk to you afterwards to give you my information to go through with that. But when you're looking also a patient advocate, you want to make sure that the person has the appropriate license or appropriate insurance. Many patient advocates, as an example, won't drive you to appointments because they typically don't have that level of insurance, so they'll meet you at an appointment. Where I'm a little bit different because I work for a company. I have a company vehicle. I can end up then taking that person to appointments. So that's been something that has been longstanding that we didn't know was going to be an advantage way back when we did it, because I had a company car through the employer, and we went to our insurance company and said, hey, is this covered? They're like, oh, absolutely, you're good. We don't have to charge any even more, like you're good with your level of insurance. We were like, okay. So, yeah, but making sure that they have errors and omissions insurance, that they have liability, that they're bonded, and that they have those levels. And because then what that does is that it ensures that the person that you're working with is appropriately covered, so that, you know, if they're, you know, meeting with you and, you know, they take you to an appointment and there's an accident, you know, that would be like that, making sure that insurance, you know, that the person has insurance and that's covered. But that if there is, in general, one of the reasons we have to have errors and omissions insurance, but one of the reasons why what patient advocates will not do is give advice, because we're not practitioners. Even if the person is a nurse practitioner or a doctor, we will never tell a client, it's just like, okay, this is what you have to do. And like, this is what we're, you know, because then if you do that, then, and if something goes south, then you can go, well, Darian, you know, he told me to be able to do that. Yep, and it's not my fault. Like, oh, he told me that I should use this 4-wheel walker, and I was walking and I fell and I broke my hip, and now I'm gonna, you know, sue because he told me to use this walker. You know, what I tell people then is use a walker that's been properly vetted by a physical therapist. You know, that is that, you know, you have, because you know, not all walkers are the same, not all people, you know, are the same. So you should be assessed by a physical therapist before you have, you know, the type of walker to be assessed. So, but other questions?
Earlier, this gentleman was, his first question really was getting beyond the relationship you have between the client and the physician, or the nurses, or whatever, the agency. He, I think, was trying to address system issues.
Yeah.
Like, you know, something where it comes down almost to being ignored or abuse on
Or
someone.
dismissive.
Dismissive, yes.
Yeah,
And I'm thinking,
they know more than they're telling you. You know, what don't they tell you?
right, and how do you get past some of that to get the information to share with the client? And I'm also thinking, I'm a retired social worker. I work with Comfort Keepers, well, Comfort Keepers. But people have to also know about the ombudsman program with nursing home care and that kind of thing. I did that for one client who was in assisted living. She'd fallen, and then when I went to see her, the workers were walking around me all the time. They can't do that. That's illegal, to listen to see if I'm going to start a lawsuit or something. I guess is what they might have been doing, which I don't do. It's not my prerogative to do that. But so I called the ombudsman program, and then they come in, and then they can talk with the group home about it, or assisted living about it, and fine them or monitor them so that that behavior that's illegal stops, you know, and respects the client.
Right.
Yeah.
Yeah,
Client
and
privilege.
to the point of like of things being siloed and being able to help with those, because the healthcare system is, I mean, that's why people hire patient advocates, is because the healthcare system is fractionalized.
Yeah.
And you need someone to end up being able to, you know, ask the why questions, you know, and being able to go, like in the circle of my colleagues, I'm known as asking the why questions. It's the, you know, the doctor walks in and, well, we need to do this, and my first question is, and not to be, you know, disruptive, but it's why, tell me why I need to do that. You know, even a doctor or a hospitalist in the hospital going, well, this person needs 24-hour care. And my first question always is, tell me more and tell me why this person needs it. Well, they, you know, need, you know, they're unsafe being alone. Well, tell me specifically why they're unsafe. So it gets down to the specifics of what that is. You can also, the best way is that when you look at the person's needs and you look at what the desire is, that making sure that whoever is sitting across the person is addressing those specific concerns.
Mm-hmm.
And if they're not, then there's ways to then to be able to, you know, have other people to be able to come in, is that, you know, and if you don't think that people are, always being upfront and clear. It may not be because they're being dismissive necessarily.
That's true.
It
Yeah,
might just be
that's
because
true.
they don't have the full picture of
Sure.
what this is, and so they have an idea what it is. And I've had clients who, was an example of this, is that I had a 94-year-old client, her name was Connie. She had terminal cancer, but for 4 or 5 months leading up to this, she was losing weight, and we had all these different symptoms, but we were getting test after test, and going to her primary, then when the primary wasn't available, going to the nurse practitioner, went to the emergency department twice. The first time we went to the emergency departments, they did a scan and said she was constipated. So they gave her magnesium citrate, which if anybody, and it was liquid magnesium citrate. And so 10 ounces of magnesium citrate, and the doctor said, when you go home, have Connie drink this, and then she should not be constipated within a day or two. Connie drank about 4 ounces of it and said, I'm absolutely not drinking that. This is disgusting. It's horrible. So we said, all right, well, what about Miralax in your coffee in the morning? Have a cup of coffee in the morning and at night? Sure, absolutely. She did that, so it took a little bit longer. And then about 2 weeks after that, she was having severe pain again. So here it was, as a person, and worked with her for 3.5 years as her advocate, just really trying to figure out what was going on. No one seemed to know what was really going on. We had done, urinalysis, had checked her stools, had done blood work, had done all these things. And finally, the second time she was in the emergency department, we said, could it be something else? Could it be, a gallbladder? It could be your, pancreas. Could it be something else? She ended up having pancreatic cancer. And she lived, after that emergency department visit, for about 3 weeks after that.
Yeah.
But
Pancreas cancer is bad.
so sometimes you don't know, and as her advocate, I was like, we missed this, and not until the hospitalist came in at the very end, and he said, he goes, this is very common, like people don't talk about it. He goes, like, this is common, this is how most people find out that they have terminal pancreatic cancer is through a scan, and because it got missed, because someone said, oh, it's, she's constipated, so they couldn't see in the scan that she had a tumor around her pancreas.
In the same scan, they could see that in the first place.
Right, because that they could see it, and then, but in the imaging, it got missed. And then I said, well, we took it, I was scanning like 3 weeks ago, and he's like, yep, it takes 2 or 3 times, for
It's
that.
a screw up, yeah.
Because and it's not necessarily even a screw up. It's just this is what they're looking at, and because of the constipation, they were looking at the.
You gotta remember that, just as an aside, pancreas is behind the transverse colon.
Yes.
If you've got stool there, you're seeing the stool, and you're not necessarily seeing the
Absolutely.
aberration,
Yep.
the abnormality in the pancreas.
Right, that's exactly what it was, and so that was for the first one. So it wasn't an error on anybody's part. This is what they were seeing. So we were treating.
Must not have been a stool in front of the.
Yeah, and that
pancreas, I
was-
guess, in this case.
Because she ended up having, it took a couple days for her not to be constipated, and then she was pain-free for about 2 weeks, and then that's when we were like, okay, it's not, due to her being, bloated and having constipation, there's something else going on. And then not until that was done a second time and we go, can we search these other areas? So sometimes it's a bit like a puzzle trying to figure something, even as an advocate, being able to figure that out. So an advocate is that second set of eyes, and not necessarily a second set of opinion, but it is just observation, and then data collecting and letting people make choices.
Comfort Keepers has hired you, right? They hired you, yeah.
Yeah, I work for
What do they look for? Are you a nurse or background in something in the medical field? Or?
Social work
If
background.
I leave her here
Social
Yeah,
work?
social work background.
Okay.
for an event.
All right.
So what was your question?
One first to comment is, I literally was just with a vascular surgeon this morning, and a younger, very professional young lady, and her comment was, she said, that's the trouble with our UW system, we're all in silos.
Yeah.
I thought that was really interesting when her and I were having a conversation. But I wanted to ask you, you know, with the whole My Chart, why is there so much that the patient cannot see? And I'll give you an example. So next week, they had me scheduled for 3 appointments at UW.
John Ziegler.
They had nothing listed what they were doing in the first appointment, second appointment. You know, you just look on My Chart, it's this time, and they don't put, and so I called, I was like, what's this for? You know, and she said, I know, that's what's so frustrating with My Chart, it doesn't, so how do you as a patient advocate, how do you see that, even if you got access to My Chart?
It's typically because I'm the one who has
You're
either
making the
made the
appointment.
appointment, so then I typically know, then that's where the piece of.
But see, the orders were put in by another physician for that, so I can't see the orders neither.
Yeah, and then so what, in those cases, then what I do, because that's what happens to me quite often with clients, is that like, oh, we'll look and there's all these different orders in, or I had, went in, a client had a blood draw, and there was also a urinalysis that was supposed to be done too, and we're like, when was that ordered? You know, like we didn't know, and then, but I looked back quick and I was like, oh.
But can you
this
see
was-
the orders?
I can see the orders, yeah.
But how
through-
come we can't see it?
Through, well, I mean, not necessarily I can't see the specific order, I can see when the order was put in, like in the chart, so when it was put in, but it's typically, so I can see that the order was put in for like the UA, for us to be able to have a urinalysis done for the client, so it's the date and time that it was put in. I typically, like, I make the appointment, so I know then what the appointments are for, and if I'm coming in and there's a list of appointments that are scheduled, I'm calling the physician and asking like, okay, this is neurology, I get it, but what's the purpose of the appointment? So then I know, so then when I prep the client, then I can go, okay, this is what we're working with. Like the client I just took to the neurologist, she was having Parkinsonisms, and they had done a scan to check if she had Parkinson's disease. Came back negative, she didn't have it, so now it was, okay, she's still having tremors, what now, what do we do? So that was the purpose, but that was from just one simple appointment, because a lot of times too, people are, you know, you're sitting in the appointment, they make an appointment, oh, let's do this, I'll see you back in 3 months. Well, why? You know, and that's where then you get the, so following and being able to figure out why. And if appointments are made, or orders are made, then calling the clinic and calling that person going, tell me why these were made. So, you know, it's always your right to be able to have that done. So, does that answer your question?
Mm-hmm.
You know, most people, I shouldn't say most people, but a lot of people have, you know, long-term care, but what about those people who just have Medicare or something like that? How will that pay you for something like your situation?
No.
Yeah.
That it's the, with, that is the, there is not a good system for people who like, with people who are utilizing Medicaid, they, you know, there's a team of people that will cover it. There's a nurse, there's a social worker, you know, so that you have that team. But if you, but Medicare does not have. I just learned this week there is a program through Medicare. It's called the Guide Program, and anybody who has Medicare Part A and Part B and has a diagnosis of dementia, or there's a belief that the person has dementia, that there's up to 76 hours of respite that can be provided for care. But there's only 2 providers in the entire state that will do it.
Yeah.
So, but yeah, Medicare in general is not covering it. Now there's, if you have Medicare Part C, so if you have like the Dean Health plan, they will cover some things. Like if you have the Dean Gold plan, you can call and you can ask about that. But if you have traditional Medicare Part A and Medicare Part B, you're not going to get home care services or patient advocacy coverage. So people are paying out of pocket for those services. So, you know, it's, and that's where as a patient advocate going and, you know, making sure like, okay, does this person have the ability to pay? And if they don't, then are there grants that we can figure out what to do and to be able to do that? But yeah, it is that it's a frustrating part because it feels like the only people who are able to get the services, especially that people who haven't applied for Medicaid yet, then you're in that in between. And you might be paying anywhere between $90 to $250 an hour for a patient advocate. It's not inexpensive to be able to have a patient advocate there. Yes?
I have a question. Does the patient advocate role ever go beyond just being there? I mean, with everything you've described so far, beyond that to being the person that would make a healthcare decision if you weren't able to make your own decisions and you had no one else?
It's a really good question, and it's a topic that has come up over. I have been a patient advocate for 8 years, and I've had one client and that was Connie, who I was her healthcare power of attorney once she was found to not be able to make healthcare decisions. Typically in the role of patient, so the role of patient advocate and then healthcare power of attorney are two separate roles, because in a patient advocacy role, patient advocate should not make medical decisions, where a power of attorney then really is really, that's a part of the requirement. So what I will do is, and what I did in this one case is that I separated the roles. And I knew Connie well enough when I said, okay, Connie, before I'll even consider being your patient or be your power of attorney for healthcare, I need to know what your wishes are. And at that point in time, then I was able then to discontinue. Once it was activated, I was no longer her patient advocate anymore. I was now her activated healthcare power of attorney and making decisions on behalf of her. And because that's how, and realistically, that's how I am not an attorney. I would talk to your attorney about this, but that as an advocate, what I would highly recommend is you should have two people that when you fill out your paperwork for your durable power of attorney, but then those two individuals should know what your wishes are, and it is not up to, essentially what you're doing with the power of attorney for healthcare is you're giving consent to another person to make decisions that are your decisions. It really should not be up to that individual, and many times people end up thinking like, oh, I'm the power of attorney, I'm just gonna do really whatever I want. They don't necessarily say it that way, but that really like, oh, well, I'm in charge now. Not really, it's just you now have legal authority to make decisions that should have been made by the person who was there. So yes, so you can do that, but the roles should be separated. So you can go. So yes, I've done that one time for people. The hard part is that there's a lot of solo agers,
Right.
and they're ending up and there's no one else.
Right.
And so then people are, the challenge has been, I had one client he was 66 years old, and he's like, I want you to be my healthcare power of attorney. I'm like, I'm gonna retire sometime, like, I'm not gonna. And so what we did in that situation was I said, I will do this until I'm no longer able to, until I'm, in a position where I'm not able. And he was like, okay, perfect. So if something happened between that, then I could do it, but I had to create a system for that, but yeah. So does that answer your question?
Yeah, because we have friends like us that have no children, and they did a number of years ago because of a major health issue. They decided, and it sounded like it was a nurse that was doing this, advocacy. They got to know them quite well, and I believe that they made her their power of attorney also. So they've had this long relationship.
Sure.
So I'm just kind of like, okay, so is this becoming more common? Probably.
It is, it's a common question, and there's nothing unethical or illegal about it. So to have been an advocate and then also then become a power of attorney for healthcare, is that because the two roles are separate. As an advocate, you're not making decisions for people, in this, you're supporting and advising and making sure that they have all of the tools and information to make decisions, and then enabling them to make it. And so, I have clients who have made decisions that I would not have made at all. And you then at that point in time as an advocate, then you have to go, okay, because it has dealt with health and safety. Like I work with a lot of people who have chronic mental health and who have addiction and, you know, who have been in and out of rehabilitation and who will sit in the hospital and go, I'm never gonna drink again. And then the minute they're discharged, they're like, hey, can you go take me to Target?
Right.
And then they're buying, you know, the largest container of gin that you could know. And you're like, okay, now what do I do? Like, so that is, so being able to, in those roles, but yes, the person is, and what I will tell people ahead of time is like, I need to have something in writing that tells me what your wishes are. The downside to, in my view, as an advocate of the durable power of attorney is that if I right now have a cardiac event or some kind of event that 911 is called, and I'm unresponsive and EMTs come in and I don't have a do not resuscitate bracelet, the EMTs will make decisions that I have no ability to consent to. So they're making decisions. So by the time a lot of times people that are making those decisions, things have already been done.
Yeah.
You know, it is that decision of where people call it the pull the cord decision. Like, grandma had a heart attack, they responded, brought her to the hospital. Now she's 94 years old, she's on a ventilator. It's like, what do we do now? It's like, well, what I would encourage people to do is make some of those decisions ahead of time. Like, if you don't want to be resuscitated, you get a do not resuscitate order in place. You know, this, do you all remember the show ER?
Mhm.
That, like, this is not, one of the, actors riding on a gurney, going down a hallway and, giving, people and pounding on their chests and reviving people. It's a very small percentage of people who will be resuscitated. So,
Right. Right.
but yeah. And we have about 5 minutes left. Did anybody else have questions? Or
I'm
did
thinking, would relate to what she was saying with the POA. In an emergency situation now with a longtime friend of mine where I became her POA while she is in the ICU unit. And I had to ask the nurses, I said, is she mentally competent to do this? And so it's like you have to sort of coordinate with the nurses, there's the staff there, and the competency. It's not so much the physical issues, but it's the mental competency. Can she agree to this? Can she sign the forms? They wrote up the forms, and they asked her in my presence, I was in her presence, if I can be her power of attorney. She says, yes. And they had the forms right there. And they asked me, is she left-handed or right-handed? I said, I've never thought about that, but I think she's left-handed. So they gave me the pen, and I could give it to her to put it in her hand. And then we had a board behind the documents so that I could put that document closer to her, and she could make her sign. And that's all there was to it. But there were witnesses available at the time, and so when there's a crisis, if somebody's in the ICU, depending on their mental status at the time, you can still do that, even in those last few months, maybe, year, who knows how long.
Yeah, there's a follow-up to, and there's a next step to that. And this is where having a patient advocate would help, because so she at that point in time, so if she didn't have a durable power of attorney established before, and so it sounds like she did not. So then, they wrote it up then, but then, she then agreed to then have you as her representative.
Yeah.
Now, the next step to that is then, it's called a letter of incapacity. So that a doctor then, the two physicians then have to sign off on that this person they don't believe is able to, in their judgment, able to make healthcare decisions. And then that's when the power of attorney for healthcare is activated. Because I've had many conversations with people, and you're like, oh, do you have a power of attorney? And they're like, oh yeah, already done. And I'm like, is it activated? And people look at me and go, yes. And I'm like, well, I don't think it is. I mean, and like, I just met you 5 minutes ago, and I'm like, I'm not trying to be argumentative with you, but I don't think it is. You're walking and talking, and seem to be coherent.
Well,
And,
what defines an activation?
and activation is when then of two physicians then state that this person is not due to their, whether it could be their current state that they're not able to make healthcare decisions. In those situations, like people have accidents, they're in an accident and they're unresponsive. They, maybe they had an induced coma, and so then they activate a power of attorney because then another person then can make a decision. And then after that, like I had a client who had a stroke while driving, and ended up his power of attorney was activated while he was in the hospital, and then once he was discharged, the doctors did a screen and said, yes, you're able to make your own, and so they rescinded the power of attorney for healthcare at that point in time. So it can be done, but yeah, it's not just getting the durable power of attorney paperwork done, it's that so that's the first step, is you have to have the paperwork done, and then having those people understand, like when I did mine, because in the state of Wisconsin also, your spouse is not automatically your first person. They'll typically go to that person, but it's not legally, it can be anybody, as long as they're over 18, it can be anybody. And then, but to make sure that you have the paperwork done, that the people know what you want, because when I did mine, because I'm a facilitator for advanced directives for people, and I had my wife do it, and then I called my aunt and said, hey, would you do this? And we started talking, and she asked me what my wishes were, and she's like, would you want to be resuscitated if you were in an accident and want to be resuscitated? I said no, I don't want to be. If I'm have a trach or things like that, no, I don't want to be, and I don't want to have extreme measures done. And she's like, ooh, I don't know if I can do that. I said, thank you, Debbie. Like, thank you for telling me that, because now I can call somebody else and ask them, because then I don't want to have to put somebody in a position to make a decision for me that's going to make a different decision than I would make. And you're basing it upon this obscure things, because in the reality, in real life, there's so many moving parts to decisions, and it doesn't always look exactly like we planned out, to be people have written these long documents, I wrote mine up, this is what I want to do, this is where I want to be. That's most likely not going to ever happen. So, but it's right at 2:00 here, so I want to be respectful of your time. Was this helpful for you?
Oh,
Yes.
I really enjoyed it. Thank you very much. I know a lot of this already, but it's interesting to hear from your perspective and your experiences.
Yeah.
So,
Thank you very much.
Yeah, you're very welcome, and I'm happy to. The senior center knows how to get a hold of me too. I can share information with you about, but yeah, I'm always a proponent that people. I'm very much about person-centered supports, and making sure also that couples and individuals have decided on decisions, and then when they have other people, whether it's friends or kids, especially it's typically parents and kids who come in that have as a side note, assisted living facilities are designed for kids, not for parents. They're intended to look nice.
You're right.
And when you walk in, kids are like, "Oh, I would love living here.
Yeah.
I'd love to have somebody
Right.
come in and
Right.
do my laundry." And would you really? Are you sure? And I'm like, you should I'll let you live here for a week, and then see after that week to see if you want to live here, and then you have to sign out every time you leave the building, and sign in.
Right.
Be able to go
Sounds good.
and you only get to eat what they serve
Yeah.
at the times that they want to eat. Oh, you want to have lunch
Sit and
at
talk to whoever they put you with.
yeah. You want to eat lunch at 1:30 today instead of between 11 and noon? Sorry, you can't get it. You get a peanut butter and jelly sandwich today. That's the
That's
that's
right.
Oh,
That's-
so true.
that's.
Do you have any business cards or anything you leave?
I like the way you put that. It really
Actually,
is.
I don't have any with me. I realize I'm so bad at. I'll look in my car real quick. I do have some on there.
Do you have any brochures at all?
I don't have brochures. I for sure don't have a brochure.
Yeah.
But yeah, I have some on my car. I'll go get some for you. So I completely
Yeah, no
forgot.
Did you ask about business? Did you ask about business card?
Yeah, I'll get it. Thank you all for attending. I really
you
hope
very
this was
much.
helpful.
Thank you. Thank you very much.